Every year, thousands of people wake up during their own surgery, fully conscious, fully paralyzed, and the surgical team has no idea. This isn't a horror story. It's a documented medical phenomenon called anesthesia awareness. In general anesthesia, two drugs are given separately, one to make you unconscious, one to paralyze your muscles so the surgeon can work. If the unconsciousness drug runs too light, even for a few minutes, the paralysis drug keeps working. A multi-center US study of nearly 20,000 patients found a 0.13% incidence of confirmed awareness with recall during general anesthesia. When neuromuscular blockers specifically are used, the rate climbs to roughly 1 in 8,200 cases. The patient hears the surgeon talking, feels the incision, and cannot move a single muscle to signal it's happening. Here's why this is possible, and why it's almost undetectable from the outside. Consciousness and paralysis are controlled by two completely separate systems. The anesthetic suppresses activity in the cortex and brainstem, the circuits responsible for awareness itself. The paralytic works somewhere else entirely. It blocks the signal at the neuromuscular junction, the handoff point between nerve and muscle. It does nothing to the brain. It cannot make you unconscious. It can only stop your body from responding. Normally, both drugs are dosed together, so unconsciousness arrives first and stays deep enough to cover the paralysis. But anesthesia depth isn't a fixed number. It shifts with metabolism, blood pressure, body fat, even genetics that affect how fast a drug clears the liver. A dose calculated for an average adult can leave another patient underdosed by a wide margin, while the paralytic, working through a totally separate pathway, keeps doing its job perfectly. This is the part that makes it so dangerous. There's no built-in alarm. Heart rate and blood pressure are the standard signals anesthesiologists watch for distress. But a paralyzed patient can't grimace, can't move, can't generate the physical stress response that would normally tip off the team. Because the same systems that would show distress are the ones the paralytic has shut down. Self-reported cases of accidental awareness documented in the UK's 5th National Audit Project were overwhelmingly linked to neuromuscular blockers, which is exactly why their use is now considered the single most significant and modifiable risk factor anesthesiologists track. This is also why depth of anesthesia monitors were developed, devices that read electrical activity in the brain directly, rather than relying on the patient's body to signal something's wrong. Clinical guidance recommends this monitoring specifically in high-risk situations, including cesarean sections, emergency surgery, and any case requiring full paralysis. The monitor exists because the human body, under blockade, is an unreliable witness to its own consciousness. What this means is unsettling in a very specific way. Two of the body's most fundamental signals, I am awake and I am in pain, were never designed to be silenced independently. Evolution built them to move together, feel pain, react, signal it. Modern pharmacology severed that link on purpose, for surgical necessity, and in rare cases the severing goes too far in one direction. The patient stays present. The signal just never leaves the body. It isn't your brain lying to you here. It's the opposite. Your brain is telling the complete truth about what's happening to you, and for a window of time, nothing downstream of it is allowed to say so.